the healthcare system in HIV is completely broken as I see it. And of course, part of it is due to reimbursement. But what's unique about HIV is that we have $1 billion carve-out that goes right to HIV care and services from the federal government. And who decides how that money is spent? Well, it seems to me like federal officials are making those decisions without adequate input from the patient community. So, no question, I'd love to find a cure. Cure is important. No question, PrEP's important. It plays an important role. PrEP doesn't help patients. Are we going to find an eradication? Well, already many, if not most, of the cure researchers have decided and said themselves that they don't think we're going to find an eradication. Fauci himself said that in Paris. I don't think we're not going to find an eradication. So now they've turned to functional cure. The whole field of cure research has always been, I think, completely disorganized, not well organized, not well thought out, not well implemented. It's unethical to implement, in my opinion, the interruption strategies that they're doing, like candy in all these studies. There are no guidelines on using interruptions. Patients don't understand the interruptions. The researchers themselves don't understand the risks of interruptions. I mean, I'm around a long time, since 1994, working on expanded access with indinavir and ritonavir, with the FDA, with some federal officials. And I just have to tell you that the way things are going right now, I think we've gone very much downhill. It's become much more political than ever before. It used to be more patient-oriented. It used to be oriented towards the needs of the patients. Now it's very political. You know, in the earlier days, in the 90s, the advocates or activists were mostly HIV infected. And they may not have known all the science, because that's what I've devoted myself to understanding the science as best as I can. But they were patients, and they understood what it was like and what their needs were living with HIV. Today, most of the advocates, as I see it, are mercenaries. They're careerists. There are some with HIV. They're not 60, I could tell you that. Most of the advocates are advocates or activists. I wouldn't even call them activists today, frankly. Mercenaries. They're not over 60 with HIV. How do they understand aging? They don't. In fact, when I was 52, I thought I was, coasting, okay? Now I'm 67. Now I know what it's like to be aging with HIV. And I could tell you that most people just don't understand. It's like a lot of things in life. You don't know what it's like unless you have it. It's like, if you want to get money from Congress on hepatitis C, you find a senator who has a family member with hepatitis C. That's how it works. So just a little bit of history. So I started NATAP in 1996, and my early work was, expanded access with ritonavir and indinavir, it started, I guess, when I slipped and fell by a pool in Mexico, embarrassed to say, and I fractured my wrist. I was about 52, and that's when I went to my doctor, and I had never been tested I had never done a DEXA. Never. And which was my doctor's fault, and I take some responsibility for that. I should have known better, I think, and he should have known better. Anyway, that was 15 years ago, and of course I did a DEXA. I found I had osteoporosis, I had surgery, I had pins put in, and then I started in my wrist, and I was lucky I had a great surgeon at here in New York, a wrist expert. And I started looking around. As you know, I've been covering conferences since 1996. I started looking, and I pore over all the data at all the conferences, particularly CROI. And I started looking around, what's going on in this world of bone and other related things. But my first interest was in bone. And I started to see presentations at conferences here and there on these things. I mean, I don't think they were calling them co-morbidities, they're bone or heart disease or something, but no one was putting this all together. And I put it all together, and I think I was the first one to realize and recognize this problem with aging. And the first thing I did was, it took me several months to set up. Well, the first thing I did was started through my email service educating the field and the community about aging and bone and comorbidities. And it wasn't getting any traction, I don't think, not much. It took me 5 years to convince the advocacy community that this was a problem. And after several months, I formed an ACT. I used to be in the ACTG on the old HIV RAC committee. I don't know how many people remember the old HIV RAC committee with, Chip Schooley and John Mellors, Judy Courier wasn't even, there yet. She was on the Women's Health Committee. And there was a lot of fighting with them back then, between me and them. So I went to the ACTG and I said, I want to have a bone educational day symposium. So I planned with the ACTG. It took a bunch of planning, and we had a one-day, full-day event on bone and HIV. And I set the agenda. I had Pablo Tabas come in and speak, and an outside bone expert speak who was also working in the ACTG, and a couple of people. And at the end of that meeting, we formed the ACTG Bone Committee, which is still existing. It's not doing a lot now, as much as it was then, but it's still existing, and I've been a member of it ever since. And then, as I was still trying to move this along through the stakeholders in this field, eventually, I think it took several years, and eventually I found my way to convince the advocates, and also to, and I had a relationship with Bob Eisinger in the OAR, and a little bit with Jack Weitzcarver, the former director, but more with Bob. And I had approached them about this issue. And I said, we really need to move this, to do something about this. And to my surprise, Jack and I had put together a list of requests or demands, however you want to put it, that I submitted to Jack and to the office and in advance, and I gathered together some of the advocates, 5 or 6 of us. We went down to the NIH in Bethesda and we met in their office. And when we walked in the door, Jack, gave us everything on that list, everything. There wasn't even a word of discussion. Whatever you want, you got it. Then I said we need a one-year panel of experts that I wanted to be on to discuss what are the research initiatives. And that's part of what we need today, I will say to Maureen. We need a panel of experts. Not a long-term, something very short-term, to talk about what are the needs. We also need, I'm calling for a national discussion on aging. So, we need a national discussion on aging that includes all the stakeholders. And, back in last fall, there was a 2 or 3 day meeting, NIAID meeting on cure research. And the day after that, and I watched the webcast, I didn't go. The day after that, the OAR had a roundtable discussion with their committee, their advisory committee, about cure, and to discuss the presentations at the conference and to have some back and forth. And there was several community people on it, and Steve Deeks was on it. There were, 10 or 20 cure-related researchers on it. I don't recall it. There were no objections brought to interruptions, but how come? And then I raised the issue. I saw one of the presentations from someone from, I think, the NIH or the OAR, and I emailed her, and I said, what about the ethics of interruptions? It wasn't discussed. I had a conference call with her. She said, let's have a conference call. She defended interruptions. Everything I listed about the ethical concerns about interruptions, she defended the interruptions. And then I had a call from a big ACTG researcher, I won't tell you who in front of everybody, you all know who he is, who said, I'm calling you because the ACTG is concerned about your emails, raising concerns about the ethics of interruptions. They're concerned that their funding will be lost. And he explained to me why it wasn't a concern, and then I explained to him all my objections, and at the end of the conversation, he said, you're right. There is no informed consent. I know what informed consent is. I was in the ACTG. It doesn't work. There's no informed consent. Too many patients have no idea what they're getting into. It's like interruptions, which I knew would never work in the mid-90s. I warned advocates about it, and they all did it, and it harmed a lot of patients. And it's the same thing with interruptions now. Sure, they're more structured, they're more watching more closely. What about CNS escape in the brain from an interruption? Are we even talking about that? No, not really. So I would suggest that we need a panel. And we need a panel of some aging researchers and so-called experts in the field, many of whom are in the room today, to meet with the OER to talk about what we need to do in research. And we need to bring the key stakeholders here, because this is a healthcare system problem. It's not just the patients and the clinicians, it's the healthcare system. I'm in New York, and I am more familiar with the New York community than any other city. And I tell you that what's going on in New York City is horrendous. And there are some New York clinicians here. Feel free to express your opinion if you want about this. But my experiences are in the healthcare systems in New York, in the private care and the public care system, 10 minutes in and out, 15 minutes in and out. There's no way that a person with HIV with higher needs, particularly a person who's aging with HIV with 5 comorbidities, on 10, 12, 15 medications, suffering with cognitive impairment, suffering with osteoporosis, isolation, there's no way that you can deal with their issues in 10 or 15 minutes. And the best you can do is, very little, I think. And then referring them to specialists around the city, whether they're in the same center or not, navigating the healthcare system for aging patients with cognitive impairments is very difficult. When you get a referral slip, go see this kidney guy at Mount Sinai, go to this cardiologist over there, and then we'll talk about it. First of all, the doctor really doesn't even speak to the kidney guy. He sends you there, but they don't speak. How do you conduct care that way for an aging patient? I mean, I can go on and on about that, but I think the message is clear. And you heard from both speakers and from others here today, but I want to repeat it because it comes from someone who experiences these things now. Isolation. You may not think that Jules Levin experiences isolation, but isolation, and it was talked about, stress and anxiety. I think everybody with HIV has PTSD. Some may not realize it, some deal with it better, some don't deal with it as well. HIV is extremely traumatic, as was said by one of the speakers here today. Everybody has PTSD. What about the legacy of lipodystrophy? So, I could spend a lot of time talking about that. Let me just say that I feel that a very much disservice was done to the patient community by the 10 years and millions of dollars we spent on lipodystrophy research. We found no understanding of what caused it. We found no solutions, no treatments except surgery. And I think that was a tremendous disservice. We owe more to the patients. And let me just say that, so at 67, being a member of the first generation to survive with HIV, and they're, it's a significant population. By the way, 80% of people in the United States are over 40, 45. This is a trend. This is not just a small group of people. This is going to get worse. 50% are over 50. Soon, by 2020, it's estimated 50% are going to be over 60, and 25% already are over 60. So, and of course, there's the issue that some people love to talk about, that, well, we don't know, and it came up here, we don't know if you start heart early at 500 or 800. We don't know if you're going to have the same problem with inflammation and comorbidities. And my answer to them is not. It's going to happen. It may not be quite as bad as it is right now. It's going to happen because HIV itself causes inflammation. Unless, if you start heart the day you get HIV, then maybe you can prevent the inflammation and the immune activation. And it's still just a maybe because we saw data on that. And there was other studies conflicting with that. That was just one study you heard, but there have been other studies of CROI showing that if you start in the early days, that it doesn't eliminate all the inflammation. Most people, so you start at 500, 800, you're still gonna have inflammation, you're still gonna have immune activation, you're still gonna have viral replication, it's still gonna be in your brain, it's still gonna be all over your body. Are we gonna find a cure? Personally, I don't think so. A functional cure, I just don't think so. Is it possible? Yes, it's possible. Should we be spending money and devoting resources to this? Yes. Aging and HIV should be on equal footing with all the attention and funding for cure and for PrEP. And it's not. It's like this. That's the difference. And that's why we're here talking about it today. And thankfully, that's why Maureen Goodnow is here today. And we need two things. We need better research. We need stop the duplication of research studies. There's a lot of duplication going on. We need patient-centric research. For example, what happens to somebody who's 65 who gets a fracture? Is their recovery different than a person without HIV or with HIV at 40 who gets a fracture? And I can tell you the answer because I've had 2 fractures. So I know what's going to happen. The muscle response, the fat response, the cognitive impairment response, the frailty response, it's all different. But we don't have that kind of study going on. That's just one example of a study that we could talk about those kinds of studies in a panel advisory group with the OER to talk about those kinds of studies. The other thing we need is, and you know, I'm not convinced, and of course, you know, I got an email from the AC, I sent out a big email to them, complaining to them the other day, sending them the new Carl Goodkin study that says aging, aging cognitive impairment gets worse in HIV, that it's accelerated. That was the crux of Carl Goodkin's study, and it was a MAX study. And so, and I sent them a note saying, so what are you guys gonna do about this? And I got a long note back from them, so we need better research, but we also need services. I have 2 minutes left, so I'm just gonna say, the other part of this, so my point is, and part of their answer was, you know, we're looking into anti-inflammatories. We may find anti-inflammatories that work, we may not. I suspect that it's going to be a real challenge to find anti-inflammatories that are tolerable and effective and safe. Monoclonal antibodies, you know, safety, tolerability, questionable. So the last point I want to make is what we really need today is services. We need a full funding of support services for patients. We heard 2 models here today. I'm not sure what the answers are, which is why we need a national discussion on aging with all the stakeholders sitting around the table, including HRSA, including Ryan White, including the NIH and NIAID, and the ACTG, and aging researchers, and community groups, and advocates and patients, and important groups, to talk, to go back and forth to find out a solution. But we need services for older patients. And it's not just for the patients, it's for the clinicians and the clinics. We really need a full, complete, comprehensive set of services for these patients. And we may not have all the answers and know how to do this, as Eugenia said, and I think Meredith said too, but we need to start now. We can't wait 3 to 5 years to begin to do this. We need to do this now, and we'll learn by our mistakes. Because if we wait 3 to 5 years, there's going to be a lot of people who are dead. And one last point. We haven't even talked about the problem of what are you going to do, because Giovanni has reported data on this last year, and others have too. What are we going to do when we have 30% of people who need to be in long-term care because they can no longer take care of themselves at home? We haven't even talked about how we're going to handle it. Isn't it time that we talk about that? So, okay, thank you.